All right, I'm going to take this a little further, but also I'm going to preamble a little bit of the next step after you specify the behavior you want to change. I'm going to get to the next stage in the behavior change wheel model that we've been talking about. But first, I'm going to talk a little bit more about thinking about theory and social science theory in the context of intervention development, because I think a lot of the principles of implementation science draw on this, but we don't always have experience in this. So I'm speaking as someone who's trained as an epidemiologist in a public health school with a biologic science background, and sort of learn some of these skills. So I think this is speaking to many of those in the room who have the same experience, although I know some of you have the more senior experience of working in social science much more directly. But this is one of the translational tools that we hope to help you develop, whether it's you're doing your own social science research and understanding those theories, or you're actually engaging with other colleagues who do this with you. So I think this is an area that, for me, was very unfamiliar, and I had to do a lot of learning around. So I've sort of tried to distill this into some concepts that will help you in the work that you do on the behavioral components. But also, I put in some slides that I think are really important in writing grant proposals that can help you sort of make the argument as to why you might be using something like the behavior change wheel, or thinking about the behaviors that impact the outcomes you're interested in. So there's a little bit of a combination here. So I hope that we talk a little bit about the components of health behavior for intervention development, and then also the idea of how you can apply concepts from theories into your own work. So I think we've talked a lot about the evidence gaps, and we have some things like that. We've also got you've done some work already on your evidence practice gaps, so this is a place that we start. And then I think a little bit about this idea about how implementation science is really in this translational place. And I think that puts us sometimes in the uncomfortable position of trying to think well, what's the science of that translation, and what's the systematic approach to that translation? So sometimes we're thinking about it in the science of the implementation process, and sometimes we're spending time in the systematic steps that we take to do this work. So I think that's one of the areas that's actually quite complex in implementation science. So I think we have some evidence that using theory-informed approaches is more likely to lead to positive outcomes than as we talked about yesterday, it seemed like a good idea. Or I think even when we talk about problems and behaviors, as we found in some of our earlier discussion, we automatically start putting in the answers. Our fixes are already in our experience, and we do that naturally. It's the way we think. I want to send reminders to bring people back to clinic, but the real thing you're talking about is bringing people back to clinic. So we have to take some steps back, and I think the use of theory helps us maybe in a way have a better due diligence about, how do I actually know what I know? So I think this is a place where it helps you to use this kind of thinking to make sure you've explored the different options, and you've also thought through, do I really have assumptions here that are perhaps not correct for this particular problem in this place and time? So this is an area where I think theory can be helpful. So I think when we talk about theory and behavioral science theory in the concept of implementation science, we try to have a relatively broad perspective, because within disciplines there's very different sort of identification with different kinds of theories, but in implementation science we're generalists. And so I think in this context we're talking about theory as a set of interrelated concepts that ultimately help you predict and explain a situation. So in theory, theories can be refuted or not refuted in the context of their specificity. Now, in behavioral science, this is really something where we draw upon social sciences, sociology, anthropology, network analysis. There's many influences here on what is behavioral science. And I think a lot of people think of behavioral science as the domain of psychologists, but actually many of the other disciplines are quite influential in our thinking and our work. So I know there's several social sciences here. They can comment on that. So what we tend to do a little bit in implementation science, I think this is really helpful in being comfortable with the use of theory, is that we're often in a place where we're informed by theory. We're using it in an application, possibly, where we're applying the COMBI behavior change model to our particular problem, which we'll go into a little bit more. People test theories and build new theories. That tends to not be what we do in implementation science so much. So this is a continuum of how we think about theory. And I think most of us are probably in the first and second stage. And one of the benefits, I think, of implementation science is it helps you articulate what you mean when you say, I'm going to be using this theory to develop my intervention. And I think one of the issues in literature in the past is when you see an intervention that may have been successful or not successful, you don't know what it did. You don't see the components of it. You don't know why they chose to do it. It seemed like a good idea. They'd done it before somewhere else. It was cheap. A program officer offered them resources. We often don't know those reasons. So part of implementation science is to help you say, I did this because I found these were the problems that led to this behavior. To change this behavior, I had to, as Aditya was describing, target certain kinds of determinants. So it helps you build that. So when we talk about theories, we also have, I think, our own intuitive way of thinking of what are the components of a theory. So we all have theories of why people do what they do and what they don't do, right? So in our clinical practice, we have those theories. In our personal life, we have those theories. And those often have to do with things we say are domains. So a domain might be, she just doesn't want to do it because she doesn't have strong self-efficacy. You know, we may think that all the time, you know, about my daughter not doing her homework enough. You know, she just doesn't feel that strong about herself to do her homework. Well, that's a domain. That comes from thinking about how she thinks. And my assumption about that is part of my theory of how she behaves. So knowing what these are and the language of these is one of the challenges in implementation science, because these come from many different fields for which people spend a lot of time talking about these. And we're sort of trying to pull them out of these different disciplines more quickly. And I just want to articulate that some of these are very important and come up a lot. So this idea of how much at risk you think you are, right? So this is obviously quite relevant to HIV testing and counseling. Your perception of, can you do things? Do you have the skill to maybe handle a diagnosis? Things like that. That could be a very important concept as well. What is your emotional status? What are the kinds of relationships and social influences? So things like your norms. So there could be your norms as a clinical provider. There could be your norms in your community of practice, and they could be different than the norms you have in other settings. So understanding what these are very common approaches in theoretical thinking around interventions. So there's lots of theories out there. I don't want to spend too much time going into them, but there's some really great resources that we also have used in some of our teaching. If you want to learn more about particular types of theories, maybe you're very interested in what are social support theories, what do those look like? There are many different disciplines that implementation science draws on. So one thing I want to articulate, and I think this is really relevant too for the way we think about it, is that we often individualize behaviors in the context of focusing on what behaviors we want to change. And clearly the determinants of many behaviors we all have are influenced by other things. And so I think sometimes when we talk about behavior change, there's the concern that we're over-individualizing things that are truly social problems. And many issues are much more compounded by things like poverty or complexity of health care. And we're not giving them enough credit in saying we need to get the healthcare worker, you know, to do the testing or counsel in a way that is more patient-centered. So I think that there can be a tension in how we think about implementation science in the context of, you know, here's on the one hand, this is an ad from a magazine in the United States where, you know, there's a lot of pushback in our country on the corn industry for manufacturing all kinds of really unhealthy sugars that are put in every kind of food. And so he's sort of saying, there's this structural determinant of my weight. And she's saying, no, it's not. It's your personal behavior. You know, you're just going back for thirds. And so on the right is a cartoon that came out when New York City made a policy that was actually reducing. That's a Big Gulp. I don't know if you guys have Big Gulp sodas here, but it's like a soda that's gigantic. It actually is as big as that. It's like, you know, huge number of ounces. And there was a health department policy that said you can't sell them anymore. And there was a huge backlash against that because that was seen as making individuals blamed for something that was a bigger social problem. So there is this tension between like not wanting to blame individuals for behavior that they ultimately have little control over, but at the same time, we want to target behaviors that will change in order to come up with health outcomes because many, many things are at a behavioral level. So how do we navigate that tension? I don't have a perfect answer, but I just want to articulate it's something that we try to address. I do think that the tools that we have, the COMBI model and things like that, do have ways of addressing it, but they're not quite as obvious at first glance. So I think it takes a little more work with them to see how they can address some of the social determinants. Anyway, I tend to take a much more collective approach to public health practice, as definitely public health practice has to inform individual decisions, and there is collective improvements that can be made. So we often use a socio-ecologic perspective when we articulate maybe what our behavior is, the problem we're working on. So as Aditya had presented that logic model, This is a place, another kind of way of framing how at the center you may have a decision maker who may impact a very important health program, or you may have an individual that is making a choice about getting tested or screened. Well, clearly that is nested within many other dynamics that we may decide to intervene upon. So it's not just to say that you intervene on an individual. So in some of the work that I've done, I often intervene with mothers on behalf of their babies, or I intervene with families to support women. And so that may be something I'm looking at that second level quite a bit in a lot of the work I do. So you kind of need to position where your problem and your focus, how many layers here are going to be relevant. So how we use behavioral theories in implementation science research. I think generally we've talked a little bit about creating a roadmap for answering some of the difficult questions that we're working on. So how can behavioral theory help you really dig into a particular behavior and identify what needs to change and the components of that change? So we'll talk a little bit more about that, but I think we've kind of gotten you up to the point where you're specifying, what needs to change, but how do you do that? This can help you with that process. So, for example, do you target the providers or do you target the patients? Maybe ideally you target everybody, but you can't do everything at once. How do you prioritize? And I think Aditya gave a nice slide about maybe you pick a behavior and you look through what could be the impact for that behavior? What would be the issues that would come up in doing that work? So we go through this process, but it can give you a map. How do you understand the environmental factors that might reinforce or undermine your behavior? So this helps us take a little bit more socio-ecological perspective on it. If we understand the behavior and the perspective from individuals who are suffering from a particular challenge, we may be more able to understand what are the pressures that are leading to that choice or that experience that they're having. So one issue could be that we're trying to understand, do you change the behavior at the clinic level? Do you work more at the neighborhood level? Are there ways you can reinforce a behavior you're trying to improve in the community through the clinic? Or more vice versa, if you're working in a clinic setting, are there other supports you should provide in the community? So if we're doing, for example, something like contact tracing for TB, you may have a very strong clinic-based approach to that. But what do people think in the community? What are the factors there that you may want to reinforce so that there's not an undermining of your efforts in one setting? So this is a way that theory can also help you move into those kinds of challenges. And then thinking about, I think a lot of us are interested in when something works or something fails, how do you know what went on? How do you identify what were those ingredients that led to success, or perhaps the particular challenges in one clinic that didn't help you achieve what you hoped? So this is where you can also see how implementation science can overlap with operations research approaches, because they often look at those kinds of issues. But theory, I think, helps us take it to a higher level where you can look at something from the outside and gain some generalizable knowledge, possibly to inform other work. So I think we were talking a little bit about the clinical trials analogy. And this is a diagram I like a lot. It's not showing up on the bottom, but it's in the slide, of the idea that when theories are linked to behavior in the very early, kind of like a preclinical stage, you're really trying to understand what's the relevant theory to help you best guide your intervention. Or in the case of using the COMBI approach, what are the components of capability, opportunity, and motivation that are most going to help you move forward? So we're often doing that preclinical work of trying to specify those targets, specify components that we might act on to change. And then as we move forward, you can see that as you get into the idea of modeling, you're really trying to understand components of an intervention, perhaps, that you've already tested. What worked, what didn't work. So you can see how there's some ways of thinking through this process where you might be iterative. You might try something in one kind of preclinical approach, one kind of setting. Maybe it doesn't work so well. Maybe you try something else. You come back. As all preclinical work would be done like that, we do the same thing in our work. Any questions on this kind of continuum? Does this seem like this helps maybe help place a little bit of what the steps might be? So I think there is a scientific analogy here, but I think the idea is that we don't often see all the preclinical work that went into some of the interventions that we're familiar with, but this is kind of the same idea. A lot of that work does go on. So as we've talked a little bit about who needs to do what differently, okay, so this is what we spend a little bit of time on in the last lecture. thinking a little bit the evidence practice gap, specifying the behavior change needed to reduce that, thinking about who needs to do what. So this again is from those behavior change articles that we've made available. And then I'm going to focus a little bit on this from the literature and experience of your team. Select which theory or theoretical framework is likely to inform the pathway of change. So this is one of the really critical and challenging steps of really specifying your behavior and digging into understanding the barriers to it. And then once you've kind of done that, we always want to jump to 3, like how do we fix it? Okay, so 3 is really how do we fix it. But we need to spend time, I think, in the way that we approach intervention development in more time in phase 2. Okay, so how do I find something that will help me do that? Okay, so this is the idea where we have taught in different kinds of formats, you know, going through different sociologic theories, psychologic theories, helping people get familiar with those, and then pulling from those which ones are most relevant to your particular approach. Fortunately, since that was time-consuming, we now have what we like a lot, which is the behavior change wheel approach. So we've talked a little bit about that, and I'm going to go into it a little bit more. But it's a synthesis. There are other syntheses out there. So there are other people who have done other kinds of things where they've talked about common important theories and said these domains from this theory and these domains from this theory. Make sure these are or are not relevant to your work. So a little bit like a checklist. So I think for me, it kind of helps me look at it like this can be done as a little bit like a checklist in the concept of you don't want to not think about some kind of approach to understanding and targeting a behavior because you're not familiar with it or you have your own idea. Like, I think I know what will make my daughter do her homework. You know, like that's my idea. I don't really know. I haven't really explored it. So I find it helpful to make sure we cover more things than we might have thought are important. Okay, so the reason we teach that, I think I've just sort of explained that. Okay, so as we've gone through steps 1 through 3, I'm going to start talking about identifying what needs to change. Okay, so this is where you have a particular behavior. That's not easy to do, come up with a particular behavior. But once you get there, you focus on identify what needs to change. Okay, so we've talked a little bit about this yesterday, and I'm going to go into it in a little bit more detail. Okay, so we're going to talk about the psychological or physical ability to enact the behavior. That's the capability piece. The motivational piece, which has to do with the things that may activate or inhibit your behavior. And then some of these ideas of the opportunity, which is the physical and social environment. So this is where you might also see in the opportunity section a lot more of the social forces that pertain to what a large part of our society that's out of our control may have influence over us. So for me, I feel like the opportunity should be like a really big bubble because these are kind of all the same size, but I feel like there's many, many pieces usually that go into that. Okay, so physical skills. This one's pretty straightforward. I know how to wash my hands effectively. Okay? Knowledge. I know the correct techniques. Cognitive and interpersonal skills. This is under psychologic. So there's different ways of thinking of this. I can ask patients, staff who are waiting, to wait a moment while I wash my hands. Thinking about your own memory processes. I can remember the steps. So this is kind of, you know, it's easy to think through for something like hand washing. Perhaps harder to think through for something that's more complex. I can break the habit of not washing my hands at critical times. Okay, so these are having to do with things that are very important in understanding the psychology behind your capability. These are kind of the things that are like, can someone physically do it? So these are assessments you might try to put into place. Do they know what they should do? Do they know how? Do they remember? So these are all things that you might go through the process in an evaluation. You're trying to understand why a healthcare worker is not conducting testing. You might try to understand these things. This is not just why aren't you conducting the testing. So these are things you might do in an observational way. You might do these in an interview way. You might do these in other kinds of qualitative methods. Okay, so then thinking about opportunity, physical context and resources. So are there resources to wash my hands? Are there working sinks with water? Okay, so that's one that's pretty straightforward to figure out if there's evidence for that in your setting or not. Social influences. This can be quite large. In this case, it perhaps is less of a large societal force. Is hand washing so frequent? frequently something that my peers and supervisors would expect me to do. So this is one example of thinking about a social way people may look at this issue. What are the social influences? So for your particular areas of interest, you can go through this process and think, you know, what are the physical opportunities, or what are the barriers to those opportunities that are physical in the particular work that I do? And you may decide there's nothing there. You don't need to target anything. In some situations, you'll say, I really need to target that. This helps you go through which of those are going to be helpful. So what aspects of the environment might influence whether or not somebody is able to perform a particular behavior? How might the views and opinions of others influence their decisions to do it? Okay, so in the sociologic context, these particular attributes in the COMBI model come from social science theories that have found that things like social norms are extremely influential. For example, theory of planned behavior on clinicians' behaviors. So there's a huge amount of literature behind the idea that social norms influence provider behavior. So that the COMBI model has pulled these together. This specific one there's many studies showing that this is true. Whether it's true in your setting is part of what the COMBI model is helping you evaluate. You may identify that the theory of planned behavior, this concept of social norm, may be irrelevant in your setting, but maybe it is. So it's important to evaluate its relationship to what you're interested in. Okay, so motivation, I think you just brought up a really good example. Perhaps beliefs about consequences. I don't know what the barrier was if you were to interview the men, or what the counselors may have found that led to the men's tent, but I'm imagining that there's some issues that may have come up here about feeling, perhaps they felt emotionally anxious, or maybe they felt, you know, embarrassed. I don't know what they might have felt, but that's something I'm sure that through the process, that information was learned. Now, did you do a systematic study to identify that? Probably not, but you identified that as an issue that came up from your evidence that you were collecting, that men were not coming. So you adjusted your intervention. So these are the kinds of domains that can be really important in the context of clinical practice. Your role, you may be motivated to do something because someone's watching you and you will get in trouble if you don't do it. Or maybe your role is to feel proud that you have this ability to do really effective counseling, and your role is to do effective counseling. So you're open to an intervention because you have a strong sense of your role. You may feel, I don't know how to do that counseling, so I'm not going to do it. So this is very common. People don't often feel they have a set of skills to do a new aspect of counseling, perhaps. How optimistic you feel. I feel that if I give counseling, they'll get the treatment and they'll get on therapy and everything will be improved. Like you may think, you know, they don't have any medications at the clinic. I don't want to test somebody, or it's going to lead to all these repercussions. I'm not optimistic about things. That's also belief about consequences. Your intentions. You may intend to do something, or you may not intend to do something. There's lots of things that influence your intentions. There's a lot of other theories that look at intentions and goals. So those are things that you might be able to think about and plan about versus something automatic, which we know a lot of things we do are not rational. So this takes into account, and this is harder to survey people about, right? So there's some kinds of barriers or issues you may come up with in looking at motivation that require observation to understand what's going on, to really explore something like an emotional experience someone may have or a reaction to a particular issue. You may not just be able to go and ask them. I'm sure the social scientists will back me up here that surveying people about certain kinds of topics doesn't help you get the answer. So there's different methodologies to address some of these issues. Does that seem okay? So then these are some of the kinds of questions that you might want to know the answer to. I'm not saying these are always going to work as survey questions. So the idea that the questions are there on the slide is to help you kind of identify what I consider to be not always obvious terminology in terms of some of these domains into things that are kind of a little more conceptual for us. So in the lectures we're giving, this is a lot of like over information about this approach and model, but the book is an excellent resource, and there's an online version of it. We have some copies here if you want to flip through it at lunchtime and later on. But it goes through a lot of examples, and I think if you're looking at this in a practical light, you could say, we have good information about this, or we don't have good information about this. I never thought about it like that before. Okay, so this is an example of some of the work that I've done on reducing families' consumption of sugary foods. So in this context, thinking about the mother's role and their particular behavior, do they have the physical ability to prepare healthy meals? Do we need to think about interventions that are like cooking programs, or do they have the skills? This is like an issue of capability we're looking at. Is there a buy-in of knowledge of healthy benefits of less sugar? These are things that we can have answers to. Some of this is easy to capture. Some of this took more time. Do people have access to or own appropriate ingredients? Social opportunity was huge in the work that I did on this. Do people have friends and family who approve of changing their dietary practices? So in the work I did with mothers, this came up as very important. They needed to have peer supports. They didn't necessarily have them. Some women did, some didn't, but they felt that was critical. And then ideas that it's, good for your health. This was something there was quite a lot of positivity around. But this one took a little more time to tease out. How would they feel about themselves if they made this change? What are the ways that we could understand that? So these are things that are ways of looking at the same problem or behavior in a variety of perspectives. Okay, and then we've talked a little bit about the combi component and the idea of the hand washing example. So this is the kind of thing where I think, as Aditya's pointing out, and Fred, you don't necessarily have to do a gigantic number of studies to evaluate this. Do people know how to clean their hands? Yes, staff have these skills. Do they have the knowledge of the technique? Yes, they do. Is the physical opportunity okay? Is there alcohol gel available? No, there's not. You don't need to do a study to determine that alcohol gel is not available on an example like this, okay? So, do people see senior doctors clean their hands, okay? So this is one maybe you need to have someone observe, right? I'm not sure you can survey to get this answer, So you may decide that may be a day. You may have someone in each of the clinics go and be a fake patient or go and, observe in some kind of way. This isn't super complex to evaluate this. So then getting to the motivational ones, this may be something that you need to understand. Do staff value this skill? This may be something that you have to think a little bit about. How do you get that data? Okay, and then do people have established routines? A lot of the automatic automation and interventions that address it have to do with setting up routines, setting up things that become automatic for you. This is an example. I think you guys had the paper that we wrote, but this was adapted from a student project, and this is mostly based on literature review. Okay, so she was looking at the issue of whether or not in the emergency department people were prescribing certain kind of medications to pediatric patients. And so she evaluated to what extent from the literature there was an established understanding that providers do or do not know about this. So the understanding was this guideline's been around for a while. People know about it. There's not a lack of knowledge on that. There was data to support that. There were studies that looked at that. So I think the idea is that in an example like this is that you can identify in the kind of logic model concept what are things that you could understand about this. Now you may decide to attack very few of these. That doesn't mean they're not important, but I think you go through that process. Like, will it make an impact? Is it feasible to address this intervention? Do I have buy-in with my community stakeholders that this is a way forward? So those are things that you do that help you move towards narrowing down the kinds of things you might do next. And obviously, we've spent a little bit of time on this, but she didn't spend that much time on this. This was a homework assignment from a student in one of our classes. And so we thought it would be useful to show to other students because it was something that she was able to pull together more quickly. Now, if she wanted to validate that in her particular setting, that might be another step in the sequence of what she would do. But this might be the first step. Okay, so now we're going to play a little bit of matching. So this is audience participation. Okay, I want you to look at the first one there, physical capability. And I want you to think through, is that thinking your dean values implementation science, anticipating feeling sad when this lecture ends, intending to stop smoking, having skills to take a blood sample, having time to perform microscopy, being unaware that a second antenatal visit is important. All right? Okay, so there's limitations of this theoretical approach, and if we had time, we could have the social scientists come up and tell us some things that are in addition to the few I've listed here. But behavior is complex, but models are intentionally simple. Okay, so this is oversimplifying what we know goes on, but it helps us move more quickly through the sequence of developing interventions, right? I don't want you to spend your career sitting in a place where you're trying to gravitate through all of these. And they have some generalizability, but there may be circumstances where they're not as useful as others. So it's something to think about. Okay. All right, so just to summarize, Aditya's taken you through defining the problem in behavioral terms, selecting some target behaviors, hoping to specify that more, narrowed it down to a particular behavior, and then I've talked you through a little bit about how you might understand what you need to identify to change. And then we're not going to do the rest of it today because that would be overkill, but we will move through, and this is compatible with the articles in the book, the idea that once you have decided it's a capability issue, an opportunity issue, some motivational, what then is the function that you want your intervention to do? So this is where we tend to be like reminders or information, education, training, persuasion. These are things that we naturally gravitate to when we talk about our problems. I want to help persuade moms to do the screening, right? We immediately jump to persuade. So this is helping us open up a little bit more ideas before we jump to persuade. Maybe in the end, persuade is right. And we'll talk about those options next. But the idea is that you spend a little more time here really thinking through the determinants. Okay, that's it.